I'd like to welcome all our participants to today's webinar. This is Dr. Marnie Peterson. I'm the Outreach Coordinator for the Antimicrobial Stewardship Project, launched last year by the Center for Infectious Disease Research and Policy at the University of Minnesota. It's my pleasure to welcome our participants to today's webinar titled Penicillin Allergy Testing, Preserving the Fortunate Accident of September 28, 1928. Which we'll get into the meaning of that title later in the webinar. As you can see, we have three expert panelists today. Dr. David Kahn is a professor of internal medicine at the University of Texas Southwestern Medical Center in Dallas, and also the training program director of the Allergy and Immunology Fellowship Program at Southwestern Medical Center. He's also the director of the asthma clinic at Parkland Health and Hospital System. Kristin Alvarez, Dr. Kristin Alvarez is the Associate Director of Clinical Advancement Best Practices at Parkland Health and Hospital System in Dallas, and is also a Clinical Assistant Professor of Internal Medicine at the University of Texas Southwestern Medical Center. Our third presenter is Dr. Wenjing Wei. She's an infectious diseases clinical pharmacy specialist at Parkland Health Hospital System and also a clinical assistant professor of internal medicine, infectious diseases at University of Texas Southwestern Medical Center. And we are just thrilled to have these three experts describe their experience with penicillin allergy testing today and the outcomes that they are going to present to us today from their efforts. A feature today of our webinar will be the ability of our participants to participate live with 4 questions in the form of a poll on Twitter. As you can see in the lower right-hand panel now of the chat box, so if you look there, there is a link to the Twitter site where the poll will be available. The first 10 minutes of this presentation, you'll have the opportunity to complete the 4 questions. The results will then be presented throughout this webinar. You can answer the poll questions even if you don't follow us currently on our Twitter account, our CIDRAP ASP account. All polling questions are single select, so please select the best answer, and all of your responses remain anonymous. In addition to this feature, at any time you can also enter a question or a comment for our panelists in the chat box in the lower right-hand column of the chat box. Just a reminder that the webinar will be muted for all the participants today, so your ability to engage with us, which we encourage, will be via the chat box and via the Twitter poll. And it's recorded and will be available on the YouTube channel after today's webinar. For those instructions, I would like to thank Dr. Kahn, Dr. Alvarez, and Dr. Wei for joining us today to present on this important topic, and to remind people that tomorrow is actually National Penicillin Allergy Day, and you can find more information about this on our CIDRAP ASP website, both information related to the testing itself as well as a CDC Get Smart Penicillin fact sheet. So Dr. Kahn, welcome.
Well, thank you very much. It's a pleasure to be part of your program. And I guess we'll begin by talking a little bit about our title here, no conflicts. All right. So this is a slide that depicts some of the key inventors, really discoverers of penicillin. On the left-hand side is depicted Sir Alexander Fleming. And Fleming discovered in 1928 a mold that had some antibacterial properties. And he went on to determine that this mold was penicillium and recognized that it must be secreting some type of substance that could be causing this beneficial action. And he named it penicillin, but was really unable to really develop this in any great detail. It took another 11 years before the two men on the right, Ernst Chain and Sir Howard Florey, to be able to work on the initial discovery of Fleming, and they were able to develop a small-scale production of penicillin, and really the rest is history. These three gentlemen went on to win the Nobel Prize in Medicine in 1945, and obviously the world is quite grateful for their contribution to science and medicine. But we're going to be talking a little bit about some of the bad aspects of penicillin, that is penicillin allergy. And before we do that, we'll start with a quote from Alexander Fleming. "The thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with penicillin-resistant organism." So we want to start off by talking about this concept that penicillin allergy, the label of penicillin allergy, does have consequences, and this has actually changed quite a bit over time. So I want to begin with a case of penicillin allergy, a 66-year-old woman with a past medical history of type 2 diabetes. She presented with fevers and flank pain consistent with pyelonephritis. She was empirically started on ciprofloxacin due to a reported penicillin allergy, and the reaction in the record was documented as anaphylaxis. On day 3 of therapy, blood cultures were obtained and were still positive for gram-negative rods. She was admission blood cultures resulted with susceptibilities to E. coli with resistance to ciprofloxacin, and we'll be hearing more about what happened with this woman later on. Well, here we go. The infectious disease pharmacist recommended initiation of Astrium and penicillin allergy testing was counseled, and we'll be talking a lot more about our penicillin allergy testing program. And here you can see the susceptibilities for the organism, and unfortunately, she's on the wrong antimicrobial at the present time. Ciprofloxacin. Okay, so when we look at early data looking at penicillin skin testing, Washington University was one of the leaders in this area, and in the 1970s, about 70% of patients who were tested in the early 1970s actually had positive penicillin skin testing. When you look a little bit later in the late 1970s, that number had dropped to about 50%. Now, moving up a few decades, Eric Macy at Kaiser has been studying penicillin allergy and penicillin testing for a number of years and published this report in 2009 showing the declining rate of the frequency of positive penicillin skin tests. So if we look at 1995, about 15% of patients that were tested were positive, yet by 2007, only about 3% of those who carried this penicillin allergy actually had positive penicillin skin tests. Fast forward now to early 2010-2012, where out of 500 consecutive patients who had this label of penicillin allergy, less than 2% had evidence of penicillin allergy via skin testing or amoxicillin challenge. And why has there been such a decline in penicillin allergy? No one knows for certain, but perhaps we are using less parenteral penicillin than we were in decades in the past. Now, there are reasons that patients do lose this allergy, and these are probably the two most common. Number one is that they were never really allergic in the first place. So we know now from several studies showing that children who have developed rashes associated with beta-lactams, more often it's the viral exanthem that they shouldn't have received the antibiotics in the first place that led to the rash, not the beta-lactam allergy. So they were really never allergic in the first place. The second issue relates to the fact that for both penicillin and cephalosporins, patients who truly were allergic have documentation of positive skin tests or positive IgE assays. When followed over time, in 5 years, about 50% of them lose that IgE. So there's a natural regression of penicillin and cephalosporin allergy over time, and this may be true with other drugs as well. So why do we care about testing for penicillin in the first place, Can't we just use something else? And one can, but the problem is this comes at a cost. So recent studies have shown that patients who have this label of penicillin allergy, as you might imagine, are treated with other broad-spectrum agents, things like vancomycin, fluoroquinolones, clindamycin, and aztreonam. And we also know that beta-lactams are superior to vancomycin for treating methicillin-sensitive Staph aureus, and that there's less failure for gram-negative bacteremia when patients are treated with beta-lactams. Furthermore, because of these higher rates of utilizing these strong broad-spectrum agents, patients develop other infectious complications, more MRSA, more C. difficile, etc., and they stay in the hospital longer and are more frequently readmitted. So there is significant morbidity associated with this label of penicillin allergy. Now, the CDC in 2016 thought this was important enough to issue this fact sheet. And really, the cartoon kind of displays the facts that about 10% of the population has this label of penicillin allergy, but when you go on to test them, only about 1 or maybe 2% of these patients truly are allergic. And in the era of antimicrobial stewardship, it's clearly important to address this epidemic of patients labeled with penicillin allergy who really aren't, and who could clearly benefit from being treated with penicillin and avoiding other antibiotics. Recently, the American Academy of Allergy, Asthma, and Immunology issued this position statement about the fact that penicillin allergy testing should be performed routinely in those with self-reported penicillin allergy. And this is quite a sea change for us as allergists. In the past, when patients would come in for whatever reason, and they may have had this penicillin allergy label on their chart, we would say, well, unless they really need penicillin, there's no need to address this. But now we're actually trying to proactively find these patients and address this penicillin allergy because of these issues that were already discussed. And there are a number of ways of dealing with this, and we'll be talking about a program at Parkland that we find to be quite successful. So here are some of the fast facts about penicillin allergy as a disease, if you will, that less than 2% of patients who are labeled as allergic to penicillin really are. And because of that, just avoiding penicillin is not a great option for the patient, or the population for that matter. Testing patients who are labeled with penicillin allergy is important, and I think it's best done electively instead of at the point of care when you need to. Removing labels of penicillin allergy is also a key task, and as we'll be discussing, is not as simply as clicking the button and poof, the label goes away, because it may come back again, and this will require a lot of effort on a number of people's parts. Okay, here's our first survey question, and hopefully this is pretty straightforward. Is penicillin allergy testing available at your institution? Yes, service is readily available. Yes, limited availability. It's in the works, or no, not available. All right, it looks like we already have the answers. So readily available, nobody has it readily available. Limited availability is 40%. In the works is 20%. That's great. And no, 40%. So I want to just kind of introduce a paper that was published based on our experience at Parkland and entitled The Proactive Approach to Penicillin Allergy Testing in Hospitalized Patients. And you'll be hearing in more detail about how we ended up doing this and our results with this. And at this point, I'd like to turn this over to a woman who made this plan a reality, and we couldn't have done it without her. So, Kristin Alvarez.
Thank you, Dr. Khan, for the background on the burden of the penicillin patient-reported allergy label. Alexander Fleming said, "The unprepared mind cannot see the outstretched hand of opportunity." So how can the healthcare community build the infrastructure to not only reverse decades of penicillin allergy labels, but also maintain the removal of that label? We have an opportunity to expand the roles of the traditional antimicrobial stewardship teams into a new area that is ripe for intervention. And as Dr. Khan said, allergists can't do it alone. Prior to dedicating resources to a penicillin allergy testing program, most institutions will want to know what the potential impact will be on patients. As Dr. Khan mentioned, we know that having the penicillin allergy label is associated with adverse outcomes such as longer hospital stays and exposure to unnecessary antibiotics. However, will removing the penicillin allergy label result in positive outcomes? There are some preliminary benefits that have been published. For instance, in our institution, we were able to show that a pharmacist-led penicillin allergy testing and subsequent label removal in the first 223 patients that we tested resulted in the avoidance of over 1,000 inpatient and outpatient days of alternative therapy. In a recent multi-center study, 2 pharmacists and 1 ID physician at each site were trained to administer beta-lactam allergy skin testing, or as they called it, BLAST, and they were able to show the percentage of patients that were receiving the preferred beta-lactam therapy for the management of infectious diseases was increased by performing just an allergy history alone, but showed significant improvement when BLAST was offered and performed. And finally, there have been studies that have shown a potential cost savings when penicillin allergy testing is offered. However, does the removal of the penicillin allergy label lead to decreases in CDI, MRSA, and VRE, or does it decrease adverse drug events associated with these alternative antibiotics, or does it decrease length of stay, rehab admissions, or hospitalizations to receive alternative antibiotics? So while there's so much to be studied regarding the impact of penicillin allergy testing, we know that individual patients do benefit when testing is offered and a beta-lactam antibiotic is needed. The first step in building the infrastructure of the team is to identify who your core members will be. You'll need to identify who your tester or testers are. In addition to an allergist, multiple disciplines can be trained to perform penicillin allergy testing. This person or persons would perform the day-to-day screenings to find patients eligible for testing and also would perform the penicillin allergy testing procedure. Ideally, they would be the ones to provide any consents and give follow-up education immediately after removing the allergy. A core member of the team includes the allergy service or an allergist. They provide expertise in allergy testing and help with standardization of the allergy screening questionnaire. They also can serve as oversight for the procedure and training protocols for your testers. And another area that our allergists have provided a very unique role is for consultation on complex or off-protocol scenarios. In addition, if there were any patients that did need desensitization procedures, then those could be easily escalated. And finally, the third member of the core team is the infectious disease service. Depending on your screening methods at your institution, you may need ID's assistance to prioritize patients to receive penicillin allergy testing. Their expertise in antibiotic selection post-allergy removal is one of their more important roles in the immediate post-label removal setting. And finally, you'll need input and involvement from the infectious diseases or infection prevention teams to help with monitoring the effectiveness of the program on the intended outcomes involving antibiotic resistance and use patterns. So now we have our second survey question, this question is, if penicillin allergy testing is available at your institution, who performs the majority of the allergy testing? And so the choices that we had were an allergy physician, a non-ID pharmacist, an ID physician, or an ID pharmacist. And the results are that 100% of the institutions say it's an allergy physician. After you've identified your core team members, it's important to remember that there are many others that you'll need to support from to implement a successful program. Your pharmacy must be able to procure and prepare agents needed for testing. Administration must support the FTE or FTEs dedicated to the testing. Nursing will most likely be involved due to the monitoring phase post-testing. Information technology will need to build an efficient screening tool and other clinical decision support tools. And finally, if your institution is carrying out these procedures in a clinic setting, then clinic support is key to expansion of your program. Once you've identified your team members and received buy-in from support areas, it's time to get started building your infrastructure. Start with outlining procedures, protocols, or policies that you will use to perform testing. If someone other than an allergist will be performing the procedure, clearly state when to escalate to a specialist. Next, engage information technology early on and see how they can assist in identifying and auto-screening patients for you after your procedure is written. While that's being built, set up a training schedule with your core team member allergists to establish appropriate documentation for sign-off on competencies. The core team members should work on creating the note templates and electronic data collection forms. Preparation of any patient education materials, including consent, should also be determined up front. However, it should be tweaked as the program progresses based on patient feedback and allergy relabel data at your institution. It is just as important to determine post-penicillin label removal follow-up as it is to actually remove the penicillin allergy in the first place. Follow-up can be in many forms, such as a telephone call, a letter, or incorporated into a post-discharge visit. Once you've established a baseline, it's time to decide how you will measure the success of the program. Initially, it'll be important to measure the efficiency of the program in terms of how many patients are tested with allergies removed, how long from the screening to remove the allergy, and how effective your overall workflow is. But then also looking at the outcomes we mentioned earlier, such as antimicrobial usage, rates of infection due to exposure to alternative antibiotics, and adverse drug events. In order to do all of this, you'll also need to create a method for collection of data so that adjustments to the program can be made quickly. And finally, start a plan to educate providers and other healthcare professionals that add allergies into the chart how to correctly document patient-reported penicillin allergies. Our official kickoff to systematically seek out patients to remove false penicillin allergy labels started in October of 2014. Our program includes one dedicated pharmacist tester with 2 trained backups. We've tested 460 patients and removed 417 penicillin allergy labels. Listed in gray are the reasons why not all patients had their allergy removed. So we had 29 that were histamine negative, 8 that were not removed because they had a dosing allergy, 5 positive pricks, and 1 indeterminate. So Alexander Fleming also said that for the birth of something new, there has to be a happening. Newton saw an apple fall, James Watt watched a kettle boil, Roentgen fogged some photographic plates, and these people knew enough to translate ordinary happenings into something new. So how did we translate penicillin allergy testing into something new? And I will pass this over to Wenjing Wei.
Thank you, Kristin. So in the next couple of slides, we'll be discussing the penicillin allergy testing protocol at Parkland. Our penicillin allergy testing service pharmacist, which I will now be referring to as a PATS pharmacist, operates under the protocol, which is activated when the provider enters a penicillin allergy consult. The patient is then screened and removed if the patient does not meet inclusion criteria, and they are also prioritized for testing depending on the level of benefit the patient will achieve with allergy removal. And this may include if the patient is on concurrent antimicrobial therapy or have a comorbidity that would increase their risk for further infections. There are several ways our pharmacists can obtain a penicillin allergy consult. While traditionally most of the programs rely on a referral process from the primary team to enter a consult or from infectious diseases when a beta-lactam therapy is desired, Parkland wanted to maximize the number of patients for testing by proactively seeking out patients by running a penicillin allergy report. This report is ran by the pharmacist daily to identify patients. In post-implementation, there were two additional strategies for us to maximize our way to obtain penicillin allergy consult, one being the automated EMR alert and the other being a panel built with HTML, which we will be explaining in more detail at a later slide. So as mentioned, our pharmacist runs a daily report of all patients with active penicillin allergy. This is an example of what the report would look like in EPIC. So the pharmacist has the ability to filter the patients and prioritize based on the need for allergy removal. And so we may prioritize patients with active anti-infective therapy and also screen the patient to remove anyone with recent antihistamine use, is on a concurrent beta blocker, or is planned to be discharged in 1 to 2 days. Once the patient is identified to be a potential candidate for testing, the pharmacist then paged the primary team to recommend a penicillin allergy consult. And if the provider agrees the allergy consult is entered in the EMR, and this is what it would look like, to consult the pharmacist service with a reason for consult being penicillin allergy testing. This will initiate the activation of our penicillin allergy protocol. In addition to the penicillin allergy report, we wanted to better improve our efficiency in identifying patients for penicillin allergy. Therefore, a best practice alert was generated on patients who met preliminary criteria for penicillin allergy testing. And these criteria was discussed earlier, which included patients with an active allergy on an active antimicrobial therapy that's not a beta-lactam, and also recent use of antihistamine or beta blockers. The provider will then receive this alert in the admission navigator shown below, and they have the option of ordering a consult for penicillin allergy testing. In addition to the EMR alert, the penicillin allergy consult was also built with the H2N order as a panel, so that anytime H2N is ordered, the penicillin allergy testing consult is also automatically ordered with the H2N. As we know, H2N is often used in patients with penicillin allergy testing. It may be an inferior antibiotic and is also very costly. Overall, we found that the clinical decision support interventions was very effective in helping us identifying patients for penicillin allergy testing. Once we've identified patients who may be eligible for testing and we receive the consult, the allergy pharmacist performs a bedside assessment, which performs a detailed history of the type and the onset of allergy for the patient. And this is documented in the EMR. After the pharmacist explains the skin testing process to the patient, he or she then obtains patient consent. And this step of the process oftentimes may be very challenging, as these patients who sometimes have had penicillin allergy all their lives may be uncomfortable with the idea of skin testing. And our pharmacists really have to be a great salesman in convincing and prompting our patients to agree to penicillin allergy testing. Then the pharmacist prepares a skin testing kit with all the necessary supplies to perform skin testing. This is a panel that's orderable in the EMR, which includes the pre-pen, the Pen-G, which we prepare in the pharmacy, as well as the oral amoxicillin capsules for the graded challenge. In addition, the diphenhydramine and EpiPen are also ordered in this possible setting of a possible reaction. The pharmacists also have the ability to document in the EMR after these medications are administered. This brings us to our third survey question. If you do penicillin allergy testing, what does your procedure include? Skin testing only, oral challenge only, skin testing and oral challenge, or none of the above? Looks like our results are in. 43% of the audience reported skin testing only, 0% is doing oral challenge only, 29% is skin testing and oral, and 28% is none of the above. So here at Parkland, looks like we are in the same group with the skin testing and oral challenge. And so we have a 3-step process, which begins with the skin prick test, with a major and minor determinant, as well as the positive and negative solutions. This is followed by the intradermal test, and if that's negative, that is followed by the graded oral challenge. Anytime that the test becomes positive leads to the termination of the skin testing. The reason that Parkland included the oral challenge as part of our penicillin allergy testing was to increase the sensitivity of the penicillin skin test from 97 to 99%. After the skin allergy testing is complete, our pharmacist then documents the screening as well as any contraindications as well as the result of the penicillin skin testing in the EMR. This is a documentation tool that was built to help our pharmacists achieve accurate documentation based on a click button system, and this will automatically populate the progress note, and it's also very effective for data collection at a later time. So this brings us back to our patient case who underwent skin testing by our allergy pharmacist. Looks like patient underwent skin testing, had a positive immune reaction to histamine, but did not have any reaction to any of our antigens, so this was negative. We then performed the intradermal test, and we did not find an increase in wheal size greater than 3 millimeters. So this was also negative, which ultimately led to the oral challenge, which the patient tolerated, so this patient had a negative skin test. So this brings us to the question of what happens after a negative allergy skin test. Originally, when the program first started, our penicillin allergy pharmacist would remove the allergy, document it in the EMR, and page the provider with a negative result. And that would be the end of the involvement of the allergy pharmacist in the antimicrobial therapy. The primary provider at times will either change to the preferred beta-lactam therapy, and other times we observe that sometimes non-beta-lactam therapies are continued despite the ability to use a more effective or more narrow-spectrum beta-lactam agent. There was no consistent recommendations from the allergy pharmacist to the primary team. Based on this observation, we identified that there was an opportunity to involve antimicrobial stewardship in the penicillin allergy program. Our allergy pharmacist did report uncertainty about making specific antibiotic recommendations without adequate infectious diseases training. Therefore, we decided to involve an infectious diseases pharmacist to serve as a mentor for the penicillin allergy pharmacist, and this was initiated in May 2016. And this brings us to our next quote. The more complex the world becomes, the more difficult it is to complete something without the cooperation with others. And that brings us to our next topic, the role of antimicrobial stewardship mentorship. The goal of this mentorship was to provide support and guidance to our allergy pharmacists and to support them clinically to optimize antimicrobial therapy after the penicillin allergy removal. Furthermore, the goal would be to establish collaboration between the stewardship and allergy services. To support our allergy pharmacists, infectious diseases pharmacists reviewed topics of infectious diseases and also antimicrobial therapy in the beginning of this collaboration. Furthermore, after every allergy removal, the pharmacist met daily to review the chart for possible interventions. So now the process after allergy removal included reviewing the chart with the allergy pharmacist and also paging the provider to discuss any interventions regarding antimicrobial therapy. Then the provider will have the option of changing to a preferred beta-lactam therapy or reviewing the recommendation and implementing any changes. Overall, there are several types of interventions with the involvement of antimicrobial stewardship. The most common one being de-escalating or escalation or optimizing therapy to a beta-lactam agent, but also because the chart is reviewed, sometimes unnecessary antibiotics are discontinued, additional workups are often recommended, or a referral to infectious diseases consult service is also completed. In addition, with the involvement of antimicrobial stewardship, referral of patients who would also benefit the most from penicillin allergy testing are also given to the allergy pharmacist. Overall, we felt that the involvement of antimicrobial stewardship pharmacists improved the types of interventions made after allergy removal without directly involving infectious diseases in the skin testing process. This brings us back to our case. The infectious diseases pharmacist discussed the case, and we recommended to stop estronium and change the ceftriaxone for E. coli pyelonephritis and bacteremia, which is a more narrow-spectrum beta-lactam agent. I'll now hand the microphone back to Kristin.
So now we have our final survey question, which is, do you have a mechanism to address penicillin allergy relabel after removal on the medical record? And the options were yes, we have educational materials. Yes, we have some sort of clinical decision support like best practice advisories or something like that. Yes, a combination of different things, or not sure, or it's not an issue. And so we have 0% for 1 and 2. There are 17% of participants who use a combination of things, and then 83% that fell in the either not sure or not an issue. So penicillin allergy relabeling has been reported to be as high as 49% in the literature. After all of the time and effort that we put forth to removing penicillin allergy labels, we should be conscientious of the burden relabeling has on the healthcare system. It is important to maintain the allergy removal if, in fact, the relabel was a result of either patient misunderstanding or resistance of other institutions, such as outside pharmacies, healthcare systems, or doctors' offices, to remove the allergy from their records. So what measures have we put in place to prevent this from happening? In our institution, we identified this as an issue fairly early on, and over time have implemented multiple checkpoints to try to thwart the penicillin allergy relabel. All patients have counseling at the time of the negative allergy testing, and the tester removes the allergy immediately from the chart with the time and date and results of the test documented in the allergy section of the chart. In our system, you're able to see the deleted allergies, and this is where this information is kept. All patients that had an allergy removal also receive a post-discharge visit. Usually this is virtual, with a standard set of questions about items such as if they remembered being tested and if they remembered what those results meant. This visit is also to see if they had any delayed reaction to any beta-lactam therapy prescribed. In addition, we implemented a BPA that alerts providers that a penicillin allergy was added back, even though the patient tested negative. In the BPA, the date and time of testing is shown. A duplication of this BPA is sent to the penicillin allergy tester as an inbox message so that they may follow up with the person adding the allergy back on and also with the patient. And finally, the patient is given a wallet card to alert any other institutions that have the allergy listed of the results of the testing. So because of all these interventions, we've been able to maintain a very low relabel rate. So as I mentioned earlier, we've removed 417 penicillin allergy labels. Over time, 46 of those labels were added back on at a subsequent visit within our system. So after the interventions that I had mentioned earlier, really it was following up with the patients after we saw that the penicillin allergy had been added back on. We now have only 4 that remain relabeled at 0.9% since October 2014. So I'd also like, this is the end of the presentation, and I wanted to just acknowledge the many people that helped us start this program and get us to where we are today, listed here. And I will open the floor up for questions. I think I had, let me scroll up here. We had a question about, Marnie, I think you had one earlier.
Yeah. Just the poll, regards to who actually implemented the allergy testing. From our poll, we had 100% was the allergist physician, and I wanted you to talk through with Dr. Khan, also present there, about your decision to train a pharmacist. And so, yeah, go ahead.
Sure. And you talked about the number of allergies. Okay.
So I think it's pretty apparent based on the numbers involved of patients who have penicillin allergy. Allergy is actually a relatively small specialty, and there's, around maybe 5,000 or 6,000 allergists that practice, and we would probably all need to convert to full-time penicillin allergy testers to be able to handle the magnitude of patients who have penicillin allergy. So that didn't seem like a viable solution. It's what we've all done in the past when there's a need arising, and that is okay. But when we're trying to address this in a proactive fashion, a multidisciplinary approach was really needed. And I'll have Kristin answer why we actually went with the pharmacist. There's the simple reason, and then there's probably some more complex reasons.
So that is true. The simple reason was we had an opportunity at our institution to expand some of our, put some innovation into some of our pharmacy programs, and there happened to be an article that was published that same year about penicillin allergy labels versus patients who don't have penicillin allergy labels out of Kaiser that really showed that these patients are at higher risk for C. difficile, for MRSA, and for VRE infections, and also have longer hospital stays. And so that article just happened to come out at the same time that we were wanting to innovate and get into some other areas with pharmacy. And so we stepped up. We saw that hand outreached of opportunity, as Fleming said, and just jumped on it. And luckily, we were able to find a candidate that was able to, as Wenjing had mentioned, it's very important that your tester is very good with patients, can build a good rapport, because a big part of the allergy tester is not just learning the procedure and getting signed off on the competencies, but it's also having somebody who can spend time with the patient, answer their questions, because like we said, a lot of times these are people who've been reporting they've had penicillin allergies for years and may actually be fearful of doing testing.
Can you also speak to, it sounds like over the course of the process of the program, you then involved and engaged with the antimicrobial stewardship team. Do you feel as somebody was implementing it starting today that actually could this not be an antimicrobial stewardship pharmacist that could be doing the testing?
It could be. Our model we set up a little bit differently because we actually have been promoting the expansion of some of our inpatient decentral pharmacy staff and expanding their roles. And just the way, it could be done either way, but we felt that on our particular situation, we would have our antimicrobial stewardship team act as not doing the actual testing and spending the time, because these tests can take, we do an oral challenge, so they can take 2 to 2.5 hours. So while our antimicrobial stewardship team is out there antimicrobial stewardshiping, we thought that, we'd have somebody else do the test, and then when it was time to get the recommendations and discuss that with the team, that they could do it that way, and we just felt that was a better use of our resources of our antimicrobial stewardship team.
That's great. Yeah, and it builds the sense of community and team with your core pharmacy, both decentralized and your stewardship pharmacists. We have a couple other questions that have come in from our participants. One is related to billing with the inpatient testing. Does this then fall under, if the pharmacist is doing the testing, does this get billed under infectious diseases or allergy?
So we actually bill it as a technical charge under pharmacy currently, and we just started doing that in December of 2016. I will say that we're very new on the billing side of things. So I can't really speak to billing with a lot of authority. I know that's always. I actually knew that question would be asked. I figured it would. But we still bill in our electronic medical record. We just do it under a technical charge instead of a professional charge. So it actually doesn't get billed under the professional side when a pharmacist does it.
So you presented about inpatient. We just had a question about what about outpatient clinics? It seems that can't remember which one of the speakers there, but talked about this should actually be done proactively. So it's not something that you're addressing all the time in an inpatient setting.
Yeah, that's correct. So I think nationally there's probably a little bit more enthusiasm, certainly amongst allergists, because we tend to live more in the outpatient arena than the inpatient, of setting up clinics that actually just do penicillin allergy testing. And we're actually in the process of doing that at Parkland as well. Currently, we're just doing it somewhat ad hoc, that we have patients that we schedule to do this, but I think doing it in a more efficient and effective manner through an actual clinic geared towards doing outpatient penicillin testing makes a lot of sense. And I think there's a lot of centers around the country that are doing that as well.
Great. Yeah, it seems that it would be something that would start to be happening more at regular visits or outpatient settings. A question related to before actually implementing or having the patient undergo a test, do you ever just recommend another beta-lactam that doesn't have cross-reactivity, such as Ansef, Suppositlin, or do you tend to always do the test when the alert is present?
If the patient meets all the criteria for testing, our allergy pharmacist will go ahead and perform the test, and the recommendation will be based on the susceptibility or the appropriate empiric therapy for the infection. However, if the testing we're not able to perform the testing, we have definitely recommended a cephalosporin or a carbapenem, depending on the indication, if the allergy is a non-IgE mediated reaction.
Okay, and that gets to the next question about basically an adverse drug reaction where the patient undergoes nausea or vomiting during your oral challenge. How do you address that? Is it something you put in the charts?
Yeah, so some of our patients who, under the challenge, get nauseated, most of the time we feel that is an adverse drug reaction and not necessarily hypersensitivity, and we do note that. Some of those patients are considered failures because they didn't technically tolerate the challenge, but that there's no evidence of hypersensitivity. But that can be addressed kind of in the allergy label even.
Okay. So a question, I think, Kristin, you presented that with the relabeling, you actually still had, when you went back, you still had 4 patients that were relabeled. Do you have any more information about those 4 patients? Did they end up testing positive to the test?
So they tested negative to the test, but there was some sort of reaction that occurred later. Part of our follow-up is to make sure that there isn't a delayed reaction. A lot of these patients do go home with beta-lactam therapy that may not be picked up by the test. And so yes, we still had 0.4% of patients that we did feel that leaving the label, or leaving the relabel, I should say, back on would be the appropriate thing to do because they could potentially have a reaction.
In approximately anywhere from 2 to 5% of patients who have negative skin tests and a single negative oral challenge may go on to have some type of rash later on with the course of therapy. So we know that the skin test and challenge is primarily directed for ruling out immediate allergic reactions, excludes the risk for anaphylaxis, but that there's a low risk of developing some delayed, usually benign exanthem thereafter. And in fact, the rate that we're seeing it at is actually a little bit lower than what's been published. So I think we've been pretty fortunate in that regard. But these are things, it's expected that you will see some patients react despite negative testing.
Do any of you happen to know the approximate costs that are associated with the testing itself?
The last estimates that we had, it was about $100 for all the supplies per test, and then you add in the cost of the salary, the FTE, on top of that for your institution.
Now, I think it gets a little bit now to, that question gets at what outcomes are you measuring as you move forward with this to show the effectiveness of a program? And our participants are often curious about how you turn your efforts, daily efforts, into research questions that then you can publish. So I was curious as to some of the outcomes that you track. Are you actively tracking them?
Yeah, and so, I had mentioned that, when you first start your program, really you're just making sure that everything's running efficiently and smoothly, and so what you're tracking initially, at least in our case, was just making sure that we were, screening enough patients, that we were figuring out how many patients we could see at a time, and so I think initially what you're tracking is that. And then we moved to the next step, which was the next logical thing was just to look at usage, antimicrobial usage in those patients. So were we able to decrease the amount of days of alternate therapy, right? So that usually is, at least for us, it was the next step. It was the easiest data that we could get. I think the harder part is when you start, and we did look at length of stay, and we started looking at those types of things, and we went through various iterations of that. Do we do the length of stay at the index admission? Do we do the length of stay at the repeat? If somebody gets readmitted, maybe they were able to be discharged sooner because they didn't have to get these alternative antibiotics. And so, we went through different research questions with that. But I think, and right now we're working on more of a long-term, how are we going to follow these patients, whether it's in a registry or some sort of way longitudinally, to see what their risk of some of these other infections, such as MRSA and VRE and CDI, were pre-testing and then post-testing. And so that's kind of the phase that we're in now. That's the research question that we really want to hone in on now. And, as I mentioned earlier, what's really important when you're building the program is build the infrastructure, or build your smart firms, build everything into your EMR to where you can collect data as you go. Because that's what's really going to inform, how you change your program, and then how you monitor it going forward. And I'm not sure about other institutions that are on the phone, but I know data collection and getting data from multiple sources has always been a challenge. It's getting better, but certainly that's what's kind of, where we're at right now. Do you want to?
So your program's ongoing, and you're continuing to collect data, and now you're starting to look at other outcomes such as maybe reduction in other hospital-associated infections or broad-spectrum antibiotic-related infections, such as Clostridium difficile infections.
Yes.
That's great. Yeah, I would refer to the listeners to the article that you published last year. Could you speak a little bit to that, Kristin, about basically, if you pull up that paper and you go to Figure 3, you can see the dramatic decreases across all the classes of antibiotics that you followed. Your broad spectrum, your cephalosporins stayed the same, and then you had a significant increase in the use of the penicillins themselves.
Yeah, I think one of the reasons that the cephalosporin remained the same is that at our institution, and because part of it we've generated data from Parkland, in that the risk of reacting in patients who have histories of penicillin allergy to receive cephalosporins is very low, less than 0.2%, in those with non-severe histories of penicillin allergy. So I think at our institution we're comfortable prescribing cephalosporins to penicillin allergic patients. This is certainly not the same at other institutions where they actually need various pathways to allow providers to prescribe cephalosporins for penicillin allergies. I think that's the reason that part didn't change, but everything else, as you indicated, the broad-spectrum agents went down. There's obviously good news, a dramatic increase in penicillin use as well.
A question that has come up, as you're obviously learning as you go and you have had a lot of success, are you also starting to look at other allergies?
So we are hoping to look at some other drug allergies. The major issue with that is penicillin is the only drug of any type, certainly antibiotics or others, that we really have validated skin testing with. I'm part of a multi-center group where we're trying to look at other testing and perhaps looking at cephalosporin testing to see if we can validate that. We're still in the infancy of that, but I think nationally we'd like to have better testing available. We can skin test to just about anything, but we really don't know what it means when it's positive and negative. So that's the one dilemma with moving forward on a wide scale with other drug testing in this kind of fashion.
What about other alerts? You mentioned that Astrium was an alert to then investigate a penicillin allergy. Have you put other alerts in place in your electronic medical record?
Yes. So the penicillin allergy, or the Astrium clinical decision support that we've set up is actually a panel. So anywhere Astrium is, whether it's an order set or a single order entry, it is paneled with a penicillin allergy testing consult for a pharmacist. And so it's essentially an opt-out. I mean, if you order Astrium, it's automatically linked to it. And I believe there are other institutions that have done that as well. As far as the best practice advisories or alerts that are in the system, we have a passive alert that is in the admission navigator that Wenjing had mentioned. It's in the slides where if somebody is getting admitted and they are on antibiotics, they have not received an antihistamine in the last 48 hours, and they have a penicillin allergy. So we have some screening tools built into that alert, and if they meet all the criteria, then there is a suggestion. It's not a pop-up, but it sits in the admission navigator suggestion to get a penicillin allergy consult. So that does some of our screening for us. And then we have another best practice advisory for the relabel. So if somebody relabels a penicillin allergy, and if they put it in, or it's a little finicky, if they put it in exactly the way that the original allergy was put in, they get an alert immediately saying, hey, this was a deleted allergy. Are you sure you want to, put this back on? But if it's, let's say, they put it in for penicillins instead of penicillin and it doesn't match exactly, then we catch it on the back end with a best practice advisory the next time somebody goes into that chart. And that best practice alert not only fires for the provider that's opening the chart, but there's a second ding that goes into the penicillin allergy testing pharmacist inbox so they can follow up with that patient.
That's very helpful. So we have 2 minutes left, and I'd like to just explore where you're heading next with your program, your research, or maybe even Dr. Kong can explore a little bit about the future of testing.
Well, one of the things that we actually have looked at, this has given us an opportunity, is this issue about patients who have had skin testing and received parenteral penicillin therapy, because it was thought that the risk of receiving parenteral penicillins increased sensitization afterwards. And we have an article that's actually in press right now that suggests that that's not the case, that after patients have been tested, they safely can receive multiple courses of parenteral penicillin and not redevelop an allergy. That's been clearly shown with oral antibiotics, and now we have some data with intravenous as well, and we wouldn't have been able to do that without this program. So it is taking us in different directions, and we're happy about that.
Another expansion that we've talked about over the years is, as I mentioned, it could take up to 2.5 hours to test a patient, depending on how much time you spent talking to them about the test, because of the oral challenge that we do. So we're looking at ways to make our testing more efficient. We mentioned expanding or going into the clinic setting and possibly bringing in multiple patients at one time, giving everyone consent at one time, and then educating on the penicillin allergy test at one time, similar to like a shared medical appointment or a class-type setting, so that way all patients can be monitored at the same time, and really it doesn't increase the number of FTEs that you need to put towards it, but it can drastically increase the number of patients that you're able to test at one time. So that is something that we've been talking about for a while. It's just a matter of finding clinic space, getting more people trained and doing that. So I think that that's something definitely depending. I know that there was only 20, I think it was 28% or something that did both the oral challenge and the skin testing, but the oral challenge does significantly increase the amount of monitoring and time that you spend with the patient. So if that's something that your institution is doing, then certainly looking at ways to cohort or be able to test multiple patients at one time, I think would be an efficient way to do that. But that's something we're looking into too. And then as I mentioned earlier, we're also wanting to really see if removing the penicillin allergy label does remove what the observation has been with having the penicillin allergy label. And so I think that's really where we would like to go next.
So currently the allergy testing is done in the inpatient, right in the ward?
It is, but we also have our allergists also do penicillin allergy testing on the outpatient setting if it's needed. It's just not ramped up as much here.
Terrific. Well, we're out of time, and I really appreciate Dr. Khan, Dr. Alvarez, and Dr. Wei for joining us today and their expertise in describing their experience there at Parkland. I think it's very important for all of our participants as they're trying to develop their programs. I also want to thank our participants today for joining us and to remind everyone that tomorrow is National Penicillin Allergy Day, and there's more information about that on our CIDRAP ASP website. If you go to www.cidrap.uofn.edu/ASP, you'll find the information there. Thank you so much.